The Haynes Method is a unique approach to dry needling, developed after practicing using both the trigger point and an acupuncture method in over 50,000 patient encounters using dry needling. I was very fortunate that I had basically free reign being in private practice to experiment, for a lack of a better term, experiment or practice with what worked and what didn't work. And it really gave me the opportunity to look at a lot of different options as far as dry needling. HMDN was developed after applying the most common treatment approaches in dry needling and learning which were effective and which were not. Dry needling is not and should not be used as a standalone treatment. We'll talk a little bit later when we talk about dosing. The outcomes of a single dry needling session without follow-up with other treatment to go along with it. In fact, dry needling, it's simply a tool used to decrease pain, inflammation, or neuromuscular dysfunction to a level that will make the remainder of the subject's treatment more tolerable and more likely to achieve successful outcomes. It is to be applied similarly as we would use a manual therapy approach or a manipulation or instrument assisted or cupping or any manual technique that we could use. This is the same thing. My opinion, it's the best one we have out there. And dry needling should almost always include some form of manual therapy to restore motion strength and return prior function. HMDN is not a philosophy based on trigger point therapy, meridians, or chi. A lot of the traditional dry needling approaches are purely focused on the notion of the muscle trigger point. Most of the research that we see is about dry needling trigger points, and we'll look at some trigger point charts or chart in a little bit. I've found that the trigger point is not necessarily the right approach. It's based on the concept of identification of a focal point or points of inflammation in a movement system, and then subsequently using the needles to stimulate the body's own inflammatory responses to reverse the course of that dysfunction. And might it include a trigger point? It might. However, it's actually possible, and research shows this, to identify a focal point between two clinicians and have empirical evidence to support where that location is. It just doesn't exist. We just don't have that manual ability to do that. So the answer is specifically no. Looking at the charts developed by Travell, we know that there is a large variance in trigger point locations. Further, traditional theory would have clinician repeatedly piston the needle, and we'll go over that in a little bit. The needle until a twitch response is gained. My patients have never been a fan of that, and you as the student involved in lab sessions also would not enjoy that. So therein lies a component of poor outcomes based on a patient refusal of further treatment. So I'm not a big trigger point guy. I'm not an acupuncture guy, but what we use these tools to do, we can get a great response without going to that extent. So HMDN, it's based upon the 3 phases of healing, quite simply. Our phase 1 goals, we're going to try to control pain and inflammation and prevent loss of motion. Our phase 2 goals, to restore normal motion and strength. And then finally our phase 3 goals, to maximize motion and strength, prevent re-injury, prevent future pain, and then simply get back to life. Dry needling is almost always limited to use during phase 1. During this initial phase, assessment will need to be focused not solely on pain. More to the point, the goal of assessment should be on finding the focal point of inflammation in a movement system. Furthermore, rarely is successful dry needling treatment limited to single muscles. There will always be a strength and flexibility issues and other components of the movement system that will be required to be addressed in order to give the patient a maximal probability of restoring that system back to normal. Most of my treatment protocols, so going through this approach, we definitely will learn to needle almost every muscle in the body, including some that you wouldn't think that we would. But more importantly is learning how to group these muscles into a specific movement system, say around the shoulder. There's a lot of movement that takes place there, and it's rare that it's just one single muscle. Let's say we have a rotator cuff tear. Well, we definitely can needle that and get some good response from that. But is it just the supraspinatus, or could subscap, could infraspinatus be involved as well? Is there some impingement going on? We have to address all of those components, and with dry needling, it gives us a tool to do that. As an example, a patient could present with knee pain. It should be evaluated to determine the following. Which specific components of the knee are tender and painful? Is there a ligamentous or a tendinopathy involved? Are they tender to palpation? Are they more tender during active or passive movement? Is the pain leading to restricted motion and strength? What are the other structures involved in the system? Are those structures demonstrating inflammation locally, proximally, or distally? Are other movement systems affected proximally or distally? Is there a neurological impairment coming from the spine? And then is there a neurologic impairment distally, such as entrapment or compression? So a lot of things that we have to look at besides just a specific muscle that we might want to dry needle. The evaluation is very dynamic. It's based upon the responses from each movement system, and it'll need to be reassessed at each follow-up treatment session. One of my big pet peeves is just repeatedly needling that same muscle over and over and over again without change in approach. More often than not, so my protocols are layered into a minimum of 2, if not 3, dry needling tiers. The first tier always includes the biggest muscles, and then we move into the smaller movers as we move down through the protocol. So at each subsequent visit, we have to determine through palpation, is the upper traps, is it under control now? Do we need to move down into some deeper structure? Or has it moved more centrally into the spine? So the assessment is key, both on initial assessment and then on each subsequent assessment. Additionally, returning your patient back to normal is based upon giving them a direct approach to managing their symptoms. As you identify and treat the focal points of inflammation, the patient should be assigned work to do at home for the flexibility of target tissues, and that's for inflammation reduction, and then strengthening, which is for restoration of function. Without stating the obvious, it's critical for the practitioner to be skilled at identification of landmarks and structures of the human body. It'd be impossible to needle targeted structures without being able to precisely identify them and differentiate them from other structures. A 3D anatomy application is critical to relearning the relevant structures. So I say that to go to the idea of relearning anatomy. When we live in the world of trying to strengthen the quads in order to do a better sit to stand or complete some other functional task, we definitely need a relative idea of where it's attached and where its origin, where it's attached. But if we want to dry needle the origin of the tendon of rec fem as it attaches on the AIS, well, we have to know where that is. We need specific landmarks, and we need specific dimensions of, and what we use is either finger breadths or thumb breadths to identify landmarks. And so that 3D anatomy is critical for that. Depending on the patient's situation, they may be able to be treated in the seated position. They may be only able to tolerate a sideline position in and around the back and the hip. They may not be able to get prone if they're older, dealing with stenosis. And so that three-dimensional view of where these structures are and your needle location is critical. HMDN is presented as following. We're going to look at general concepts of dry needling. We're going to look at how to dry needle specific introductory muscles, and we will dry needle complex muscles, tendons, ligaments, and nerves as we move past this introductory material. And then we'll look at specific diagnosis related dry needling protocols. And then finally, for each section, we'll look at specific perineural dry needling protocols. A lot of I call this neuromuscular. Definitely the muscles play a big role, but the neurological component is critical, whether we're dealing with something such as peripheral neuropathy, if we're dealing with carpal cubital tunnel, a lot of the entrapments in the upper extremities, lower extremities as well. So that'll be the final piece, is that perineural dry needling protocol. The last course or the last lecture in this series will be on the pelvic floor. there is a lot of good information in there. One of the more common ones we deal with is both pelvic pain and then incontinence. And dry needling can play a big role in managing those symptoms. And then finally, HMDN is based on the concept that learning never stops. Principles learned in this course will give the certified practitioner an advanced level of skill and knowledge to implement dry needling into your practice. But as you become more skilled in the technique and in the response of your subjects to its application, you'll be able to modify the techniques to adapt to the responses you see. Human body is a larger scope of knowledge than we'll ever conquer, however, and new techniques are frequently being developed. I developed a new approach for dry needling the glenoid labrum a couple of months ago, and I've now implemented that almost with every shoulder patient that I see. For thoracic outlet, I talked to my staff earlier today. There's a much more advanced approach for that. We've got a specific solid approach for a thoracic outlet, but there's a much smaller muscle and a much more potentially complex and dangerous location. I'm just studying right now how to get to that, how to needle that in a safe manner. And so we're going to continue to learn more as we move forward and apply these things. So on the idea of research, ongoing research needs to be reevaluated. The majority of research being conducted is based on the outdated trigger point theory and not on movement systems. Further, the actual needle locations are rarely included in the research, and that is a failure. For how can the research be duplicated if we're not able to use precise locations in treatment? HMDN provides specific landmarks, distances, and depths to improve upon standardization of this technique. I frequently get an update every week on new research that's being put out, and every week there's a new research study on the effects of dry needling on the upper trapezius. I think that is the most studied muscle in the history of the world, and quite honestly, it's the easiest one to dry needle. We know that it can help reduce stress and tension. We know that it can help with things. There are 6,000 other things that they could be doing research on to really help our profession and the practice of dry needling. So hopefully as time moves forward, the focus of research will shift just a little bit so that we can get a little bit more meat into what we're putting out there.